thank you for all of so thank for all of you really to invite me. Let's make it uh, unofficial really, since the number is small. Let me know if you see the screen with the slides.
Yes, we can see.
But let me just enlarge the slide a little bit. Sorry. Okay, do you see that? Just a correction first. I'm not a program director anymore. I was till 2018, then stepped down. لكن my really interest is education, the most thing, and really I'm proud Arab, I'm proud Muslim more than anything else. So unfortunately, diabetes is very common, and I don't know how much to talk about it. So let's make it unofficial interaction as much as possible, but based on our experience here in Toledo and in the other cities, we used to have 3 wound centers under us. Now it's down to 1. We used to cover West Ohio wound management in general as a team. And the more you do wounds, especially diabetic wounds, the more you know how difficult it is. But let's touch on certain things. This is actually, there is nothing for me to disclose related to subject. I hope we can cover some of those subjects now. I usually use this slide I'm sure it is a famous slide in the middle of the talk, but this is to let you know all, I'm sure you know, that diabetic foot, which is almost as dangerous as any cancer, actually more dangerous than many cancers for the 5-year mortality. It is almost as bad as colon cancer or as good as colon cancer. It is, if there is ischemic diabetic foot ulcer, the mortality reaches almost 66%. Compared, for example, to lung cancer, 88, and compared to Hodgkin's lymphoma, which is only 18%. So that tells you it is a life-threatening problem. It's an epidemic, and this epidemic is increasing. No need to go through many of the figures, but every year it is more than the year before. And it is underdiagnosed. Not only it is that this is in the United States where we live here, how common it is, between 10 to 12%. In some states, they have diabetes, in other areas, less. And it is actually underestimated because the metabolic syndrome, which predisposed to changes, and before it forms as diabetes, is very common, almost 50% in some populations. It is a hidden, undiagnosed problems. It's why many people nowadays start treating it before it happens. What about the Arab world, the Middle East and North Africa, and challenges for diabetes? This is the incidence of diabetes. Unfortunately, I tried to find the incidence in the Sudan. I couldn't find much in the literature, but Kuwait among the higher in 2000, in 2014 is still the higher, and it is high in all of them. The lowest is Yemen, but the Middle East, especially Kuwait, Qatar, Saudi Arabia, Jordan, Egypt, Iraq, is very high. And by gender, if you notice, between 2000 and 2014, like take any country, for example, Saudi Arabia. In 2000, it was the incidence about less than 15%. In 2014, the incidence about 17, 18%, both male and female. So it is increasing over the year. And it is also represented by the fact that obesity is increasing in the Arab countries. Complication from diabetes depends on, are you looking for the complication or you are waiting for the patient to present with complications? It's ranging from about 5% to about 23%, so it is common. And if we will look at actually the prevalence and incidence. Somebody tried to do, actually, Mohammed Merghani, his name is from Sudan. This is the closest I found Sudanese, actually. Did this study, systemic review. Although I was reading the study, but the sad thing, he went through 2,600 papers. At the end, he found only 9 papers that can talk about the Arab world. Generally, in that issue, the incidence or complication of diabetes is very common, and diabetic foot is very common. What about research? This is for those who live in Saudi Arabia, they know Dr. Zahrani. They published this paper about research. Again, compared to the world, the Arab countries has 1/4 of the research published in diabetic foot compared to the rest of the world. And if you divide it based on different regions of the Arab world, some regions, without going through those regions, it is even less than 10% of the rest of the world, which is, we don't pay attention to that, although it is an epidemic in the Middle East and in the Arab countries. The problem with diabetes in general, people don't follow the evidence and the practice. So 30 to 40% of patients not treated according to the evidence, clinical evidence, and 20 to 25% of care is not needed, or sometimes it's dangerous even, because people don't look at the management as a group. Everybody takes it from his own or her own. Generally, the diabetic foot ulcer and re-ulceration can occur. Ulcer incidence for diabetics about 2 to 7 per year. 9 to 20%, up to 20 of ulcers end in amputation, and up actually to 83% re-ulcerate again. And this is one of the issues. The amputation in the United States increase in different groups. Africans higher than Latinos, higher than Caucasians, and it can be reflecting the disease process, the access to care, which is one of the problems we will talk about a little bit down the road about the Arab world. This is the problem with diabetes. We are not going to talk about much of it. It causes vasoconstriction, hypertension, and muscle growth, and the new intimal hyperplasia and closure of the vessels. It adds to inflammation and causes thrombosis, platelet activation. So it is not only the ulcer. The ulcer is the tip of the iceberg. The rest of it is really a problem. Clinically, there are different ways of describing the ulcer. I'm sure you know them, but we can describe it the way we want. Infection, if there's vascular disease, neuropathic deformities, and we need to mention the etiology. And then we need to grade the ulcer. There are different ways of grading the ulcers, but the best one or the most used one is the Wagner grading. I'm sure you know that. I don't want to go through it. But the Wi-Fi, for us, the vascular surgeon group, we are using mostly the Wi-Fi, which combines the presence of ischemia, the type of the wound, and if there's infection or not. And these are some of the pillars of the reason to develop diabetic foot. The problem with diabetic ulcer and diabetic foot, it is a complex process. It's not a simple process. It has ischemia, it has infection, chronic osteomyelitis and acute osteomyelitis, and neuropathy, and bone and joint deformity. So it is a complex problem. That's what we read in the books, but the more we deal with diabetic foot, there are more of those problems, really. Social problem, depression, financial, medical access, and compliance. I call this actually as the cycle of amputation. These are the cycle of amputation. Once the patient loses work and they cannot attend work and others, this is a problem, and that contributes to loss of limb in those patients. And there are different risk factors to develop the ulcer, including the neuropathy, peripheral vascular disease, mechanical factors, ulcerations, race, smoking, retinopathy, and other complication. But the most important one, if the patient has a history of ulcer, the chance of getting another ulcer is very high. Almost one-third of them, they will develop another ulcer. And it does not mean the same ulcer. It might be any other area in the ulcer. Diabetes is not only sugar, it is a metabolic problem that affects almost the blood vessels, the bones, the leading to different deformities, and those deformities cause imbalance in the pressure on different parts of the foot, leading to callus formation and ulceration. And sometimes we ignore the calluses, but most of the time, those calluses has an ulcer in them. From different studies, the diabetes itself can cause an ulcer, but there are other factors that will contribute to the ulcer formation in diabetic patient. And those deformities predictive of ulceration. And sometimes there is no relationship between the clinical foot deformity and the ulcer location because the patient uses different maneuvers to adjust to the deformity. And based on those maneuvers, including the shoes they are using and the type of footwear they are using, will decide where the ulcer occurs. For example, if somebody uses a very tight shoes, it doesn't mean it will be in the plantar surface, it will be on where the shoes is causing the pressure. There are deformities that causes considered high risk for ulcer, such as hammer, low toes, bony prominences, charcot feet, and there are others that are considered low risk. But generally, there are areas that we look at and we say this patient is going to develop an ulcer because they have those factors. Actually, we put in some of the studies from our hospital here, some of those factors together, and we came with a way to predict an ulcer formation and to predict how to develop an ulcer, as well how to predict amputation in those patients. But this is a way to tell you history of ulcer and amputation is very high for the odd ratio to develop another ulcer. And of course, loss of sensation is very important. And this is example of those diabetic foot where the pressure will cause, and this is how you measure the pressure where they can develop the ulcer based on the pressure. Skip that. The risk classification is important in the prevention. Once the ulcer forms, you need to heal the ulcer. But it's important to prevent the ulcer, and this is where you do risk classification, and I'm showing you why we do that. But we need to understand that 11 times higher if the patient has bone exposed, 90 times higher if infection and ischemia are present in a patient with with diabetes. Osteomyelitis location, the heel has highest rate of amputation. We have the dictum that heels don't heal, because once you have a large ulcer in that area, it imbalances the whole walking areas pressures, and that causes more ulcer that they will not heal. As vascular surgeons, I'm not going to go through how to do the revascularization, but a few notes. It is very common. It is much commoner in diabetic patients than non-diabetic patients. And almost 50% of patients with diabetes will have peripheral vascular disease and coronary artery disease, and many of them present with myocardial infarction. But peripheral vascular disease in general is 20 times higher in diabetics than non-diabetics. There is increased risk of other diseases, lower extremity amputation, 15 times higher in diabetic than non-diabetics, and ulcer in diabetics have about a 10% higher, and amputation is higher. You all know the angiosome theory. Some of us believe in it, some of us don't believe in it. But I will say something about the angiosome theory, whether you believe in it or not. In general, when we revascularize patient, we've been taught since I was a medical student until now, establish one vessel flow to the leg. because there are connections between them. But the research shows actually some of the choke vessels, we call them choke vessels, CHOKE, are not working in patients with diabetes. Those choke vessels is like the choke in the car. If you choke the area, it will open different areas. In diabetes, it doesn't open. So the different areas supplied by different blood vessels work in silos, like many other things in life. And because of that, many people advocates that if you revascularize a diabetic foot, try to open more than one vessel. Your job as a vascular surgeon and my job and everybody's job who's dealing with wound, not to say if the patient has severe vascular disease, just to say there is a vascular disease, whether arterial, venous, or mixed. Doppler signal does not mean there is acceptable blood flow because, it's calcified. And we have to be very aggressive in the diagnosis and treatment, but doesn't mean that we have to do unnecessary procedures. And we have to master, as vascular surgeon, both endo, open, and hybrid procedures to be successful in diabetic patient. Vascular care alone, because everybody thinks if I revascularize this patient, they are going to heal. The answer, vascular surgery alone, even if you give the patient the best vascular procedure, doesn't mean they are going to heal. You have to do other things to make them heal. How do we look for blood flow in the leg? It's not angiogram, it's not arterial Doppler studies and pressure. You need to look for occlusive disease, which is mostly in the infrapopliteal segment. Best way is by ultrasound. When you see there is a change in the acceleration time and change in the waveform, you know there is a disease, and you should have a very low threshold for intervention, which means disease, diabetes, and ulcer means intervention. Don't wait, the patient might heal. You need only to establish blood flow to that area as long as possible, as long as it is needed to heal the wound. You don't need really very long patency, and you need to use different maneuvers to do that. I'm not going to go through them. There is a lot of talk nowadays in vascular about perfusion rather than measuring pressures or others. Perfusion, we try to do some research on it. And the earliest perfusion techniques, whether it is fluorescent angiography, whether it is plethysmography and others, so far are not optimized. We found that in some patients, and Ayman, he was with us, he was the PI in one of those studies actually. Even after revascularization, the oxygen saturation goes down. Number one. Number two, people who are dark in color, which means the African American, the brown people like us, is not going to be accurate. So the companies pulled some of those perfusion devices and they are optimizing them. Actually, we are buying a new one, which hopefully it is optimized because it's very expensive. The other thing, we always learned in the past that diabetes has a problem, which is distal vessel disease, microangiopathy. Whatever we do is not going to work. That might be accurate to some extent. But if you increase the inflow, you are going to improve the perfusion. And you should do your best to increase the inflow to the foot, to the ulcer area as much as possible. So don't worry about there's microangiopathy. Microangiopathy, yes, interferes with healing at the very distal part, but if the larger vessels, when I say the larger vessel, I mean the posterior tibial artery, dorsalis pedis, peroneal arteries, are occluded, the amputation, instead of being a toe amputation, will be a below-knee amputation, which is minor to major. The other factor we have is hypoxia. Hypoxia because of microangiopathy, there is prolonged hypoxia, and that will cause injury and that will delay healing. So we need to find a way to counteract that hypoxia. The third factor in diabetes that it is a prolonged healing. The prolonged healing means the bacteria will start making biofilms and chronicity occurs. The problem with diabetes, what we learned about in healing does not apply to diabetes. The cells are not normal, macrophages are not normal, platelets are not normal, reaction is not normal, collagen is not normal, nothing is normal there. So you need to help by reducing the chronicity with frequent debridement. One of the studies came from actually one of the wound companies, is what many people don't believe in it. You have to do debridement once a week or once every twice a week. Doesn't mean you have to cut all the tissue, remove the superficial layer, which has the biofilm. Then how to test and how you diagnose neuropathy. Many of it related to circulation or microcirculation, but there are ways to check for neuropathy, and how to deal with the neuropathy is beyond our scope as a vascular surgeon. You need to work with a team who can deal with Charcot foot, correction of Charcot foot, or at least footwear that will correct those abnormalities. And they contribute a lot really to developing ulcers. Charcot foot is the enemy. You need to look for it. And usually, actually, when they come to the clinic, I look inside their shoes to see where the pressure is. Most of the time, the area where the ulcer is forming is the area where the highest pressure inside the shoes. And then you initiate after that, sending them to a footwear company in order to adjust it. And this is where the Charcot happens. Some of them are difficult to deal with, some of them are easier to deal with, but generally, the midfoot is the problem. Once you have the midfoot, and it is a problem because if ulcer occurs in that area, there are those joints. If you penetrate one of those joints, it's an end of it. You will end in amputation. Infection, we all know it's very important. You have to treat. Sometimes suppressive therapy is needed. We cannot tell you what antibiotics. It differs from hospital to hospital, sometimes from country to country, but you have to have, again, a low threshold for treating infection and looking for infection. Don't wait. If the patient has a small area of infection, you have to be very aggressive debriding and treating that infection, because it will spread very fast. And it usually spread along the synovial membrane more than anything else. And there are fungi, anaerobes, aerobes, all of them. Don't start by treating all of them. You need to follow the hospital recommendation for the bacteria in the area. Start with those. Try to be more specific than general. If it is a lot of systemic effect, go to the general more than the specific. So you need foot care, very important. You need to treat infection, revascularize, offload. In diabetes, that the rule is offload, 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 like in venous, compression, compression, compression. We cannot offload as vascular surgeons, so you need to deal with a team that will offload. There are ways to measure where the pressure and how to deal with different shoes. I'm not going to go through that, but just to tell you, it has to be done as part of the healing. Otherwise, those, by the way, to remove part of the foot sole doesn't work. Some of them work well, some of them don't work well. This is actually one of the patients, you apply the cast. Again, the cast, although it helps in the forefoot ulcer, it can cause infection somewhere. We hardly use those external fixators, but in many places they use them. What about hyperbaric oxygen therapy? We said one of the areas for diabetes is hypoxia, microangiopathy, and sometimes you cannot really improve the blood flow to the distal organs, especially if they have osteomyelitis and penetrating ulcer reaching the bone, or Wagner 3 and Wagner 4. This chambers, which is spread in many areas, actually, this is our chamber. When we established it, And the person in white coat, Dr. Zelenak, if you know him, he's a very famous vascular surgeon. And you can apply hyperbaric, but there are certain approval points. You have to approve it by insurance, and the approval can take some time. But generally, HBOT indicate that you can improve the amputation from major amputation to minor amputation, improve the healing of the wound, especially with osteomyelitis. And if you look in the literature, it's not very confirmed that hyperbaric is going to help. The reason for that, because people sometimes apply hyperbaric to the wrong indication. It is not only in the wound, like some people use it for stroke, myocardial infarction, for ischemia, etc., etc. But you have to have the proper indication in order to get the proper result on those patients. It decreases the healing. The complete healing improves with using hyperbaric. And you have to watch for complication. They are not that common, the complication. The problem in the United States, it is uh, available in a small number of centers. It is expensive. A full course can be 50,000 to 200,000 in the USA. It is time consuming. The patient has to come 1 hour to 2 hours actually a day, and they have to stay 5 days a week every day. So it takes a long time, and so many people don't like it. And many physicians say it's very costly, but if you calculate the cost that it saves by healing the wound and improving the condition versus the expense, it is really cost effective rather than costly. However, HbO2 should not replace the standard of therapy. You should revascularize, treat infection, offload diabetic, podiatric care, then use also hyperbaric if it is needed. Some of the areas, some of those wounds, like we treat with hyperbaric, and it works. There are keys to success to dealing with wound care in diabetic patient: communication with the patient, the problem economy, because patients are not working. If there's no insurance, it's very costly. I actually sometimes attend clinics in Jordan, and I don't know how people even are able to tolerate the expenses, very high expenses. The most important thing, you need to educate the patients and educate the physicians about wound care in general in diabetes. It is multidisciplinary approach. With the presence of EMR nowadays, you can follow on the healing and you can predict the healing. But the problem with EMR, electronic medical records, sometimes wrong information entered in wrong results. And this is a problem in itself. If the patient doesn't heal in 4 to 6 weeks, then there is something going wrong. It doesn't have to heal fully, but to show signs of healing, then restart the cycle again, which means now it is chronic. Try to make it acute wound. Rethink, what are you missing? Should you use tissue therapy? Should you use skin graft? Should you use different offloading, different shoes? Should you change the dressing? And so on. You cannot continue doing the same thing if the patient is not showing signs of healing. The Einstein said applies here. It's crazy to keep doing the same thing if they are failing. Sometimes, though, vascular surgeons, plastic surgeons, podiatrists think because it's only thing they know how to do well, that is the answer. We call for every hammer, everything is a nail. And that is wrong, especially in diabetic prevention of amputation. You need to treat ischemia, infection, osteomyelitis, and neuropathy, and nobody knows how to do all of them together. You need a gatekeeper. You need to consult people who you don't have in your service. We need to have diabetologists to treat them if you cannot, vascular surgeon or endo surgeon. And the vascular surgeon, if they only do open, that's a problem because most of it nowadays are done endo. In our area, in our hospital here, 85% of the cases are done actually endo. Even if yesterday we opened the anterior tibial artery, the posterior tibial artery, popliteal artery, SFA, all of them were included endo. I know recommendation you should not do that, but it works until the patient heals, and then we come back. If we need to open more, we open more. The problem, different studies show different result, but that's what worked for us, so we do that. The gatekeeper is the person who is in charge. It can be a primary care physician, can be a hospitalist, it can be a podiatrist, can be a vascular surgeon, but somebody who knows what others can do. And that is the most important thing. You cannot just do what you think you need to do. In some areas, there is a response team, and we established response team in the past, but it needs a lot of money. And that response team starts where the patient hits the ER, then goes to the floor and goes to the center. And it helps reduce the 30-day readmission, increase wound patient capture rate. You track the patients from the admission to the follow-up in the wound center to home health or extended care facilities, and reduce the price ticket on dealing with patients with diabetic foot. And all these are important and improve the quality of life. The other thing, you have to have a protocols. You should not cut corners. If you have a patient who comes with an ulcer and your protocol get arterial study, get the arterial study. Many patients know he has very good Doppler signal. No, get the full arterial study, the way you have a protocol. And it is known that those protocols improve care, reduce time to heal, improve access to necessary care, and leads to patient with better satisfaction. And also frequent removal of biofilm, like we say, every 2 weeks, at least clean the wound. Don't cut corners by not cleaning the wound. Check, make sure the patient needs footwear. So this is part of the checklist that you have to do. So you need a protocol and follow the protocol. The problem with wound patients who have chronic wounds, they are older, multiple medical problems, possibly need a caregiver. They don't have family members around them, especially in this part of the world. They need extended care facility. That's why you need somebody to arrange for and integrate that service. And this is exactly what we need for diabetic care. All those people, they need to be involved in diabetic care. But where to start? You start where to prevent amputation. And also you need to start by treating the current condition and plan management. If you don't integrate it, you will end in amputation and you need a gatekeeper. This is actually, we came up with this in our hospital many years ago. The minute the patient comes with a wound consult, we do all the necessary imaging and consult the necessary people. We are vascular surgeon. Our team is a vascular surgeon team, but they are doing the wound service in the hospital, in the wound center, and in outreach. From there, we know the name of the patient. We take it, we put it in our list, whether it is a paper list, whatever list is, and we tell an advanced practice nurse, either a PA, physician assistant, or a nurse practitioner, that they need to make sure this patient is being followed up in the wound center. We manage the patient in the wound center, our team. We follow them wherever they go outside. If they go to the hospital, we treat them in the hospital, and the APP follows in them in the hospital. The APP arrange extended care facility if they need a nursing home, or send them home with a home care, or just home to take care of themselves. And we make sure we involve the social worker, and we involve the social worker on our team in the discharge plan, and we follow the patient either in the wound center or follow on them in the nursing homes. We used actually to send our nurse practitioners and PAs to the nursing home, but we stopped doing that because it's really very difficult to deal with that. So this is our way of management of patients with wound and diabetic foot. And of course, if we are going to expand on each one of those, we will need long time to do that, unfortunately, but this is the basic for management of wound and diabetic foot. Thank you for listening. I'm sorry to take time. It is only 25 minutes, 35 minutes, not bad.